have a wonderful, I think, morning session about a very important question. Is there evidence that quality saves money in healthcare? My name is Mats Bojestig. I'm a member of a strategic advisory board, and I work in Jönköping County Council in Sweden. And it's my honor to share this session. I think that a lot of you, when you went here, just claimed that it's important that we go here because we need to learn this very important topic. So we will have two presenters this morning, and you will have the possibility to put up some questions after each of the presenter. And I will first introduce to you a person that you already know by now, the President and the CEO of IHI, Maureen Bisognano, a dear friend to me, and she has also, during these days, launched a book with the title, Pursuing the Triple Aim, Better Care, Better Health, Lower Cost. And today's topic is care coordination, connecting healthcare to health and cost. Welcome, Maureen.
Good morning again. I'm delighted to have you join me again to talk about this topic, which is so near to my heart, which is about the triple aim. It's about care coordination. Can we design a better healthcare system that will produce better health and a lower cost? And then Rosemary Gibson will come up and share the stage and talk about utilization and how does that link into cost. And then, as Mats said, we will try and save some time for questions, and there are some microphones in the aisle for you. So in my session this morning here, I want to talk about some linkages between cost and quality, and then help you to think about new models of care. And when you change the model of care, can you actually produce better health at a lower cost? And I wanted to start by defining the problem. In the United States, the problem is particularly acute. So we spend about $2.7 trillion per year on healthcare, and over 75% of our costs go to chronic disease management. And if you look at costs, they're soaring in the United States. And if you look at the burden of chronic disease, it is also soaring. So our patients, as I was saying yesterday morning, are kind of trapped in silos. And the silos are contributing to the cost problem. The problem actually is pretty similar in other parts of the world, perhaps not so much on the cost side, but we're seeing this shift in the burden of illness, and diabetes, cardiac disease, obesity are increasing, expected to increase in the UK by 50% by the year 2035. So the burden of illness is getting higher. As we think about this cost challenge, I think we've got to begin by thinking about the health challenge. Let me just show you in the United States. In 1985, we started to measure obesity rates by state in the United States. And 5 years later, you can see that the burden of obesity in the United States had increased dramatically. Let me go back to 1985 for a minute. It looks like not so bad. There were a few states where there were a high percentage of obese patients, but I'll point out that the white states were only states where we didn't have data. It wasn't that they were skinny, it was that we didn't know. So 5 years later, we started to get a real picture of obesity rates by state. 1995, look at the country. By the year 2000, we had to add on a new category of obesity. By 2005, we had to add on 2 more categories of obesity. And by 2010, this is what the country looks like. We no longer have any states that don't have a high percentage of the residents there as obese. And it's not just an American problem. Again, we started to measure obesity rates, and what you can see here is, again, the gaps, the gray areas, are just countries where we don't know the answer to that question yet. And if you look at the prevalence of diabetes estimated for 2025, you can see that the burden of illness is increasing dramatically. So we've got the need increasing dramatically, and we've got this cost pressure that we've got to deal with. So I've been looking at this problem for about a decade now, and I wanted to bring you back to thinking about how I look at it. I don't believe that we can only look at cost without looking at the health of the population, the data I was just showing you, or looking at the care experience. It is all interrelated. That little black dot in the middle of this triangle is what we call the integrator. And it's the place where all three of these need to come together. So we're here to talk about cost, but I wanted to begin by saying that it's not possible, in my view, as responsible healthcare professionals, for us to focus only on that piece of the triangle any longer by itself, and that we need to understand all the implications together. So I was talking with Michael Porter recently from the Harvard Business School, and I was asking Michael, what do you think about this problem of cost in healthcare? And Michael's very familiar with the IHI triple aim. And the first thing he said was, he said that the primary care model, he thinks, is broken. He said there's disutility in the primary care model when you have an incredibly diverse patient mix. Now, I know a lot of countries are kind of going toward primary care as being the solution, and Michael Porter is saying, don't run so fast. He's saying, and he has, like I have, sat in a lot of primary care practices to take a look at what happens there on a daily basis. And he says one patient is incredibly complex, with multiple comorbidities, no social supports, perhaps no money to buy medications, a really difficult challenge for us to work on. And then the next patient might be a young child who needs a vaccination, and then you go back and forth again. He said it's no longer possible for one primary care physician to kind of bounce around that way and be effective with every single kind of patient. So he says the challenges of managing excellence with the research that's coming out on a daily basis is too much for someone to figure out alone, and that we need to redesign primary care in order to produce the best outcomes at the lower cost. And he said there's chaos in the life of physicians. So Michael Porter's view is if we want to work on this problem of coordination and cost, we should begin in the primary care office. Joanne Lynn, another researcher from the United States, has a different perspective, a very valuable point of view, which says, understand your segments. Know how many of your population is healthy. And you remember yesterday I was saying that 50% of our population only accounts for 3% of the cost in healthcare. So what's happening with that population? In my experience in the United States and in many countries where I work, those patients are ignored. They're not regularly connected into the healthcare system. They're quiet, so we leave them alone because the burden of the other patients is weighing down the clinicians. And yet, as I was saying yesterday, that's just kicking the can down the road, because if we disengage those healthy people from the healthcare system today, we're going to end up paying for it tomorrow. But Joanne says, think about the different segments in your population and think about what each one needs. How do we create a model of care that will produce coordinated care at the lowest cost for each one of the segments? At Mayo Clinic, I mentioned Victor Montori's thinking about minimally disruptive medicine. Victor has taught me that interaction by interaction, we need to think about the patient as a whole. We need to optimize the time a physician or a nurse needs to spend with the patient in order to really create patient health goals. But we also need tools so that the physician can get through his or her day in a reasonable way. I show you an example here. These are diabetic cards that Victor and the folks at Mayo Clinic use for newly diagnosed diabetics, or when a patient comes back in for a visit. And it was really quite extraordinary for me to sit in on these visits. Now, as I mentioned yesterday, I am out in healthcare organizations all the time. And mostly when I'm sitting in watching a newly diagnosed diabetic patient be educated, the physician will say, go and talk to the nurse and she'll give you a little booklet about diet, and she'll give you a little booklet about exercise, and here's how I want you to test your blood sugars, and here's how I want you to take your medication. Victor, and the compliance rates, as you know, adherence rates to medication worldwide are about 50%. So we think we're prescribing adequate medication over time, but what happens in fact when you go into someone's home is that you see something very different happening in daily life. So Victor knew that. When Victor's sitting with a diabetic patient, he lays out these cards. There are 7 cards, and each one is about this big, and they're little laminated cards, and he'll lay out the cards. One of them is on weight change, one of them is on cost, one is on low blood sugar and how stable you are, one is on daily routine. And he lays out the 7 cards, and he said there are lots of things that go into the decision about what kind of care you might want. Which one do you want to talk about first? And every time I was sitting in one of these meetings and the patient was a woman, the first thing they said was weight change. They said, well, let's talk about weight change. One of these drugs typically adds 3 to 6 pounds to your weight, and another one usually causes you to lose 3 to 6 pounds. And the women will all say, that one that makes you lose weight, I want that drug. And then Victor will point out that, in fact, that medication is $9 a day, and there's another medication that's 10 cents per day. And so if cost is an issue, then they start to shuffle the cards. I saw a businessman say, I travel every single day. I need a routine that I can live with while I travel. And so he put that card, daily routine, on top. But what you see is the patient and the physician having a conversation about all of the assets that that patient brings. And what Victor is finding is that those patients understand their disease in a totally different way than, here, take this drug, or here, this is how you eat now that you've been diagnosed with diabetes. So that's a way to think about changes in the healthcare system. And I want to give you some examples of organizations that are thinking about coordination of care as a driver of cost. Yesterday, I mentioned the NUCA project, where the folks in Alaska are working on the NUCA system of healthcare. And I included there for you some some choices that they made when they were thinking about redesign. But I want to give you a little bit of a different perspective this morning, and you'll have all of these slides in your handout. I would encourage you to print these out and go back and take a look at how they think about coordination in service of better health outcomes and lower costs. The first thing I mentioned was relationships, and they thought about every segment of their population. The first one was elders, and they thought about how do the Native Americans think about their elders? What kind of wisdom do they bring? What kind of interactions do they typically have with the healthcare system? And how should we design care for that segment? And then they talked about people who go to traditional healers. Now, normally, the typical healthcare system, the doctors and nurses in hospitals, prescribe medications, and then what happens in most cases in NUCA is the patient then leaves the physician's office and goes to the traditional healer and says, should I take this medication or not? Is there something else I should take? In other words, the patient is being treated by 2 different systems. So NUCA realized in order to create an effective system, they needed to integrate the traditional healing system with the modern medicine system. And I've given you a whole list of examples. I wanted you to have this in your handout so that you could go back and reflect, is this how you are thinking about care coordination? In the workforce, they had to create a different culture because the workforce's view of care was interactional. And they had to go back in and think about, how do we build a workforce culture that's relational, where people don't walk in and someone doesn't say, what's your name, who's your doctor, what are you here for? But they say, welcome back, how's your husband, how's your son doing, he's getting married next month, how's that going? Well, that's a different structure, so they needed to build a different way for the workforce to work. They created different spaces. As I mentioned yesterday, they focus a lot on NUCA structures in order to facilitate flow and coordination. They don't have the doctor's offices at one end of the hall and the nurse's station at the other. Everybody's working as a team because that team-based care is going to produce better healing relationships. And then they focused a lot on, as Joanne Lynn would say, the segments. And as Michael Porter would say, the daily work life and the flow of patients. The first thing they did was they tackled violence in families, which is a huge problem in the Native American population. And they created a program called Family Wellness Warriors. And they brought people from the local community in and trained them to identify domestic violence, and they created a whole system for intervention. Now that's very proactive. It's not treating the victim of violence in the emergency department. It's saying, let's coordinate the care way upstream. We'll produce better health at a lower cost. And then elder program. There's a pathway home when a young person has been involved in violence or drugs or substance abuse out in the community. They create a pathway back home. So they don't just say integrate back into the community, but they teach them healthy family relationships, and they have a process by which they integrate that young person back into the community that's very, very effective. And you can see these other residential programs for young women who are having their first children, or they have no support system, single parents. How do you take a single mother and not look at her as delivered the baby, send her home, but how do we bring her from the safe delivery into a system that teaches her how to thrive as a young and single parent, how to teach her how to care for that baby in every way, and then transition that person back into a healthy home. Partnering relationships of all kinds. I wanted you to have these resources, again, so that you could go back and say, who of our patient population is in this segment, and what does care look like across the spectrum for that population, and get some ideas from the NUCA system. As I mentioned yesterday, when you start to think about care coordination, like the folks in South Central Foundation do, you're able to dramatically reduce the burden on the most expensive parts of the system. They're seeing fewer admissions to hospital, fewer emergency department visits, fewer visits to urgent care centers, because they've moved care upstream to less expensive, proactive, preventive care, and they've moved care downstream so that once someone goes home from the acute system, they're very well capable of managing their health outside the system. So you can see here that there is a strong linkage between care coordination through segmentation and redesign and cost per capita. I want to give you another example from Ghana. We started working in Ghana some years ago on a project that's funded by the Gates Foundation called Project Fives Alive. And our goal here is to reduce mortality in children under 5. So we began again to think about how do we get to this millennium goal. And immediately, as we often do, when you look at high rates of mortality in children under 5, 110 to 120, down to 40 is our goal in a few years' time, that's going to require care coordination across boundaries in the system. Going into work in hospitals or physician office practices alone is not going to get us there. We've got about 15 people here from Ghana, either working on Projects Fives Alive or working in the National Catholic Health System or the Ghanaian Health Service. And I encourage you to seek out these folks. They have done an unbelievable amount of work in understanding causes of mortality and in creating care coordination across the system. And as they're doing that, again, they're keeping children out of the most expensive care settings and allowing the Ghanaian health system to use resources in the most efficient way. The most common causes of under 5 death are malaria and neonatal diseases, so we went and began to focus there. And just like I was talking yesterday about Malawi, we found that delays in seeking care, delays in providing care, and non-adherence to protocols, there were 3 primary levers. So we created, with the leaders in Ghana, these change packages in each one of these areas, and the results are dramatic. You can see here a 16% overall reduction in under 5 mortality in 9 hospitals. And you can see here a 67% under 5 mortality reduction in the highest performing hospitals. And the thing I love most about the Ghanaian project is they see coordination. If you walk into any one of these Fives Alive projects, they've got a map of Ghana. And they can tell you exactly where they're working today and exactly where they're going to spread. So they're moving every change concept. As they prove it, they spread it. And so they're not looking at, can I save one child's life or can I improve one hospital's emergency department? They're looking at, how do we change the entire health system in the country by building successful protocols, but then seeing that map on the wall and knowing, here's where we're at today, but here's where we're going tomorrow, here's where we'll be next year. And they've got this vision of spread across the country. So they've got now over 90% adherence to standard treatment protocols in all 9 hospitals. And the change package developed for scale-up is now being spread across the country. Some of the results are just dramatic. They've looked at nutrition services. They've looked at getting children treated when they come into the emergency department. They've changed the whole ways that emergency departments triage patients. It used to be kind of first come, first serve. Whoever got into line first would be treated next. But they realized that children who are critically ill die at a much higher rate than adults. So now they moved all the children up to the front of the waiting line, and they've seen mortality drop off dramatically. So we're seeing changes in Ghana as a result of this care coordination that are so breathtaking. Again, I urge you to seek out the Ghanaian leaders here and talk to them about their story. It's really impressive, and there are so many lessons we need to learn from Ghana and bring back to all the other countries represented in this room. And then lastly, I wanted to tell you a story about a hospital, basically a lone physician in the United States who decided that care coordination could drive down cost. And he built the case for this himself. This is a colleague of mine, Tony DeGioia. He's an orthopedic surgeon at the University of Pittsburgh Medical Center. And some years ago, his daughter was working at IHI, and Tony and I were talking about his work as an orthopedic surgeon. And he developed this model. I've given you at the end of your handout kind of a resource guide so that you can connect to this. But there's a simple model that Tony developed called PFCC, Patient and Family Centered Care. And again, he's looking at care coordination as a driver, a key lever to drive down cost. So Tony's an orthopedic surgeon. He's an engineer and an orthopedic surgeon. And he began his journey by looking at the journey of a patient. So he hired medical students to come and sit in his office. And whenever he would say to a patient, you need your hip or your knee replaced, he would assign a medical student, and the medical student would accompany that patient throughout the entire journey of care, pre-op testing, through the operative procedure, post-op, until they were fully functional at home. And what these medical students said was, when they came back, is they said there are lots of improvements we could make. And at first, Tony was thinking, well, no, I'm a really wonderful surgeon. It can't be like that. But the medical students had a different point of view. And they gave Tony a number of different areas where care could be improved. As an example, he said, I always teach my patients preoperatively what's going to happen during their stay. And the medical students would say, well, I was home with that woman when she was just trying to describe to her husband what was going to happen, and she couldn't describe it. Or Tony would think, I manage my patient's pain perfectly. And they would say, your patient couldn't get out of bed for a day and a half. And so they looked at the overall experience of care, and they pointed out all the coordination lacks, which drove Tony to redesign care in these ways. I'll give you a little example. The picture on your bottom left of the patients there on the exercise equipment, those patients had their hips and knees replaced this morning. So in Tony's area, the patient gets their surgery, their hip or knee replaced in the morning, they go back to their room, they have exquisite pain management, they get up and get dressed, they eat lunch, and then they're in the gym the same afternoon as their surgery, either on exercise bikes or treadmills. He's got them all prepared for this, so there's nobody who's surprised or distressed. They actually look forward to it. And they have classes together before, so that all the patients having surgery on a given day are in a cohort. And they're there in the gym competing with each other about who can walk the fastest or who can run the farthest. But what you see is when you build the expectations this way, when you manage expectations and pain, when you have the processes flowing quickly, all the patients are expecting to be up and walking. So here are some results. Tony's mortality is 0%. He's had 0 dislocations. He's had 1 readmission in 2 years. And people might say, well, he only operates on young people, but that's not so. His demographics of his patient mix are exactly the same as the average for the United States. My favorite statistic is 95% of his patients are discharged directly to home, with no handheld devices, no walkers and no canes. So 95% of the patients go directly to home. They don't have to go to rehab or to a nursing home. And in the United States, the average is 23 to 29%. In fact, most times when I ask an orthopedic surgeon, what % of your patients go directly to home, they don't even know, because that's not their part of the process. They do the surgery, they write the discharge order, and it's somebody else's job to get them into the right place. 99% of his patients now report that pain isn't a problem. The patients are so satisfied. I mean, I'll tell you a little funny story that in the United States, I don't know if this is the same in your countries, but in the Northeast where the weather is bad, the elderly people now have taken over the shopping malls, and they do what's called mall walking. So they've got the malls to all open up at the crack of dawn, and before the stores open, you just see elderly people walking and walking and walking because they're exercising together. It's a social situation, and they're indoors. Well, Tony was telling me that one of his patients asked for a little pile of business cards, and when she's mall walking, if she sees someone limping, she'll go up and say, you really need to see Dr. Tony DeGioia for your hip or knee. There's that kind of loyalty to him because he's designed care across the spectrum to make it perfect, not only technically, but perfect experientially for those patients. Now, the average length of stay is 2.8 days for a total knee, 2.7 days for a total hip. And you can see how that compares to the national averages in the United States. I think some of your national averages are still quite a bit higher than that. Tony's blood transfusion use is 5%, which is much lower than the U.S. national average. So the cost per case are dramatically lower. And Tony works with his operating room team so that Tony comes in at 7 in the morning, and Tony and his team do anywhere between 8 and 11 joint replacements in a day. It's because they work as a team. They know exactly what this patient is going to need. They're totally communicating on the processes, and they understand how to work with each other extremely well. So efficiency is incredible. They don't need to add on more operating rooms because Tony's using every one of them efficiently. They don't need to add more beds because the length of stay is shorter. So the costs are lower, the patients are fully functional at home, and everybody benefits from this view of care coordination. So after Tony got done with that, the administration called him and said, Tony, orthopedic surgeon, can you redesign OB? Can you redesign the delivery process? Can you redesign rheumatology? And so Tony's now using PFCC, Patient and Family Centered Care, to redesign and coordinate care for any diagnosis. But he began with his own specialty and proved to the administration that the small investment in medical student shadowing is producing huge savings and much closer satisfaction, much higher satisfaction than ever they've been able to see in the care systems before. On per capita cost, again, what we're finding in Henry Ford Health System in the United States is set a goal on harm, decreasing harm, and they started to work across the whole system to coordinate care around harm. This is an example of their C. diff rates. Now, you can't manage C. diff on one unit. You really need to manage C. diff from the outpatient setting to the inpatient setting. And most hospitals didn't even know about what their C. diff rate was when patients were discharged. So they had to bring together all of this data. And as their C. diff rates dropped, you can see that they're saving tens of millions of dollars in an average year by coordinating harm reduction across their system. So here, the hospital finance officer will show demonstrated savings across the entire system when they begin to coordinate care across the whole way. So I included in your handout some planning matrices for you to use when you get back home. The first one might be to segment. Who are your patient populations? How many people are in each segment? Where do you stand relative to the best? And so I've given you a couple of matrices. The second one is on harm. Can you count up the harms? Can you figure out, like Henry Ford did, how many patients come in with C. diff? How many get C. diff in the hospital? How many get C. diff within weeks and months post-discharge? And once you can quantify that, you can begin to associate savings. And then the last one is a driver diagram on efficiency. And again, I give it to you as a tool to use when you return home, to go back and begin to think about labor costs. Are you working effectively on supply costs? But here, what we're finding is that when people begin to use these matrices for planning, that they're getting a system-level view of the connections between cost and care. And then they have a map, a plan, that allows them to get in and drive out cost up to 1 to 3% of the total expense budget, not just 1 year, but year on year on year. So I'll wrap up by giving you some design principles on linking cost and quality. The first one is segmentation. Who are your patients anyway? How old are they? How sick are they? How many are diabetic? How many live in low-income housing and have no social support? How many people aren't able to buy the food that they need in order to stay healthy? So once you start to think about this, you're going to surface many ideas about new ways to coordinate care. Second is pick out one of those and dial up your PFCC connection on the internet and figure out how to shadow a group of patients that will allow you to see the fragments in your care. Once you can see the fragments, you're going to come up with some new ideas for redesigning care across the system. Sit in an ambulatory practice and watch whether or not the kinds of patient load that a physician or a nurse midwife or a nurse practitioner are managing on a daily basis are saying. Are they chaotic, as Michael Porter would say? And is there a way to redesign care so that the days are predictable and reliable? You might want to use the Ihi Waste Tool. This is a tool that's on our website. It's free for you to download. And anybody, a nurse, a physician, a middle manager, can do what I call a waste walk and use the tool to walk through an inpatient unit or an outpatient unit and say, should this patient be here in this bed or in this chair right now, or are they here because of a defect, or are they here because of a delay? And once you begin to aggregate up these people who are in the wrong place or here in the right place at the wrong time, that gives you a very clear roadmap as to how to drive improvements. Use those planning matrices that I gave you in your daily work. So fill those out and go back and help to see those as plans. We've got a Choosing Wisely agenda, and Rosemary will be talking about this a bit more. But here, there's definite overutilization in our healthcare systems. Begin to quantify that, because again, it helps you to build the will that you'll need in order to make process level changes. And finally, engage the finance leaders in your improvement work. How many of you are finance people? Maybe 8 or so? That's not enough? Next year we need to have this whole section here be finance people, because we're not able any longer to differentiate cost and quality, health and healthcare. We've got to bring all of these pieces together so that we're able to make the kind of progress that we need. And in your handout, I've given you a lot of resources, connections and linkages and ability to download these tools, because in my experience, when you go home, you're really going to need to build will, not only among the whole of your team, but engaging the finance person. You're going to need new ideas, and many of these resources will give you new ideas for looking at care across time and connection to cost. And then you're going to need execution help, and so all of that is available on these sites. I've left just a couple of minutes for questions, and if anybody's got a question or two or a comment, we've got microphones here in the aisle, and I'll take a couple of questions before I turn it over to Rosemary. Thank you so much. One brave soul. Or two.
I'm very interested in the use of the medical students.
Oh, yes.
In the shadowing. What kind of training do they need?
There's a short little module, I think it's 2 hours for training, and we're using nursing students. As a matter of fact, I'm running a training for all of the IHI staff so they can go out and begin to be shadowers. But it's a very small training, and what they do is they help people to see things and not take them for granted. They help them to learn how to ask questions, to keep diaries and journals, but it's very simple and extremely effective. So,
is that available?
I believe that the shadowing, at least there's a linkage in here to the shadowing training. Great, thanks. And if you have trouble finding anything, I've got my website up here.
Good morning. My name is Krishna Bhaskar Bhatla. I was wondering, why did you deliberately leave the public health issue out of the triple aim?
We consider the health of the population to be in the public health domain. We're trying to bring public health and the healthcare system together in the health of the population.
And the other thing is that the most important thing I have realized in my day-to-day practice is the health illiteracy,
Oh, yes.
Because whatever you say, I explain to my patient like this. I have this computer, but I don't know what goes on inside the computer brain.
Yeah.
If I have a problem with the computer, I have to go to my, whoever the engineer is. In the same way, I don't have mistake you if you don't know something. Just like in my car, every day I drive, if I have a problem, I have to go to the mechanic. I try to understand that, but still there are some things I don't understand. So that way they put them at ease that if they don't know, they will come forward.
That's a huge addition. And there's one of the IHI staff is a woman named Gail Nielsen, and she's here. And she's our expert on health literacy, because you're absolutely right. We're speaking in tongues, and the patients go home and they don't understand what we've said, and they can't possibly create joint patient-centered goals when we're not speaking the same language.
And the last comment I want to make is, like 20 years back, I did my master's in health promotion and health education. As a physician, all my peers ignored me. They said, you're stupid to go to that line to have an extra skill. We need to break this barrier between the physician and the physician population that, doing health promotion is not a taboo.
Yeah. No, I totally agree, but I think your time has come. I think the idea of now thinking about the triple aim is linking health promotion with the traditional kind of practice of medicine. So your time is here.
Thank you.
Thank you all. Yes, sir. One more question.
I just wanted to say thank you for a very inspirational talk. In the UK, we're going through some very interesting changes with regards to health policy. And the sort of NHS's idea is to increase market competition to try and be the driver for reducing costs. You seem to have given a very opposite explanation, which is the standardization and widespread use of best practice in itself will help to drive down cost. Would that be a fair assessment?
It would, and I will have Nigel Edwards will be up here in just a little bit to describe his point of view, but your perspective on my framing is exactly right.
In which case, one final point. Could you give this talk to David Cameron?
Okay, one final question. Sorry, Rosemary.
Just a comment really about the directors of finance. I had an opportunity to speak to our hospital executive recently about waste, and I took along 100 £1 coins and gave them to the director of finance and said, that's my gift to you, but you have to pay the money back to me every time my team's doing nothing on a ward round. So if it takes 7 minutes to reboot a computer to look at an x-ray, he had to give me £21. And well before the end of that virtual simulated ward round, he'd given the whole £100 back.
Wow.
And that brought home to him the cost of waste.
That's a fantastic example. I love that. Thank you so much for sharing. What a great way to end. Thank you very much, and I'm going to turn it over to Mats to introduce Rosemary. Thank you all.
And thank you very much, Maureen. I think it was giving us a lot of inspiration, and you're really showing us that there is evidence that quality can save money in healthcare, but there is also a lot of work for us to do to get those money. Now it's my pleasure to introduce for you Rosemary Gibson, who is a section editor of Archives of Internal Medicine's series Less is More. She has worked as a National Quality Saved Initiatives at Robert Wood Johnson for more than 16 years. She is also an author of the book The Treatment Trap, How the Overuse of Medical Care is Wrecking Your Health. And so I think that this theme of overuse, that we was just a misuse, now is the next theme. And Rosemary, we're so glad that you will present this work for us. Thank you.
Good morning, everyone. Okay. Can you hear me? Can you hear me back there? Yes. Good, thank you. I'm really delighted to be here this morning to talk about a topic that is just coming into its own. It's something whose time has come, and that is overuse. Overuse of unnecessary medical care. This morning there was a breakfast session, and colleagues from Bupa were talking about how they were handling the overuse of certain types of surgery and the practices that they were taking to try to reduce it and to provide the appropriate care for patients. It was a wonderful conversation, and it helped me understand that certainly, and this presentation will be about the U.S. context for overuse. And when you spend 18.6% of your GDP on healthcare, you're bound to have some overuse. But it's not just the United States. We're seeing in emerging markets like Brazil and India a trajectory that they could be on where overuse will become an increasing problem. And we're also seeing it in European countries where overuse is a challenge. I'd like to do 4 things this morning. I'd like to highlight overtreatment, define what it is, and how it is an emerging quality and safety issue that demands our attention. And you'll see that for most of this presentation, I'm not going to talk about cost until the very end, because the most important part is that it's about the patient and about getting the appropriate care for patients. I'd then like to turn to introduce a new series that has been launched in the Archives of Internal Medicine, a series called Less is More. It was started in 2010. And the intent is to publish research and patient narratives on overuse. And I hope you'll consider submitting articles and narratives for our consideration. A third part of this presentation is I'd like to set the context for how we can begin to engage in improvement strategies around overuse. It's a very thorny thicket because in systems such as the US, where it's fee-for-service, financial issues are certainly a very large factor, but it's more than that. It's also about physicians and their practice. If you're a surgeon, you want to do surgery. How do we manage these thorny thickets and set a context in which we can have this conversation and actually make improvement and reduce overuse? And then finally, I'll end with discussing opportunities for publishing research and narratives on overuse to keep that dialogue moving forward. So what is overuse as a quality and safety issue? This actually, well, first of all, you all know this, what I call the holy trinity of healthcare quality. We have underuse, misuse, and overuse. And it's interesting how underuse and misuse have really been taking center stage. And overuse now is just coming onto our public dialogue. And what's interesting is we have these dynamics, certainly in the US and in other countries, where we have pockets of really extreme overuse. At the same time, we have pockets of extreme underuse. So we have patients getting very high-level interventions, at the same time that we have people who can't afford cancer treatments that will save their life, or eyeglasses, something as simple as that. And as I try to make sense of this, I think about the obesity epidemic that Maureen was talking about. On the one hand, we have pockets where food consumption is at a very high level, and often the wrong type of food. At the same time, perhaps a few blocks away, we have people who don't have enough to eat. So we have this imbalance, whether it's in our consumption of food and our consumption of health care. In 1998, the Institute of Medicine Roundtable on Quality actually defined overuse. And they said it is when the potential for harm of a healthcare service exceeds the possible benefit. And that notion of harm that they put in suggests that we need to bring this in as part of our work in quality improvement and patient safety. More recently, some of you may have seen this in the Journal of the American Medical Association, Don Berwick and Andy Hackbarth wrote a piece on waste in healthcare in the United States. And here's what they said about overuse as one component of waste. It's the waste that comes from subjecting patients to care that, according to sound science and the patient's own preferences, cannot possibly help them. And they continue, it's care rooted in outmoded habits, supply-driven behaviors, and ignoring science. Examples include excessive use of antibiotics, the use of surgery, and unwanted intensive care at the end of life. And finally, they put an estimate on this aspect of care. This category represents between, they say, $158 billion and $226 billion in wasteful spending in 2011 alone. That's an enormous sum of money. Before I go there, I'd like to share with you my own journey of discovering overuse as a patient safety issue. And I'd like to express my indebtedness to Helen Haskell from Columbia, South Carolina, who's sitting right here, who's a new board member for IHI. And I first met Helen in 2002 when I was working on a book called Wall of Silence, which put a human face on the IOM report to err is human. And Helen graciously shared the story of her 15-year-old son, Louis, who went for elective surgery and died 96 hours later of what we call failure to rescue. And thanks to the work of IHI, the discovery of rapid response systems in the Australian medical literature, Maureen, you took that and spread that around the world, and people are alive today because of it. What I learned from Helen, though, was something new and different. And she said that her son's death from failure to rescue was only one part of the story. She said, there's another part. And I asked her, well, what is that? And she said, it was the decision-making process around which the choice of that elective surgery was made. Helen and her family are an educated family. They wanted the information. They wanted to know what were the complications and risks. And to their dismay, they did not realize and were not informed of those risks until after Lewis's death, when Helen went searching on the internet and found articles published in the Journal of Pediatric Surgery highlighting the risks and complications that if they had known beforehand about this elective surgery, they would have not moved forward. And we know from the literature that when patients are fully informed of the benefits and risks, and too often the risks are underplayed, they tend to choose less invasive, less intensive alternatives. So it's in the course of overtreatment that errors occur. And that's why overtreatment demands our attention as a patient safety imperative. So what is the evidence for healthcare overuse? This is largely evidence that comes from the US context. As mentioned, I'm a section editor at the Archives of Internal Medicine, and we have a series called Less is More. It was started by Dr. Rita Redberg, who's a cardiologist at the University of California, San Francisco. And here's what they said in their opening editorial, which I included as a handout online. The Archives is filling a gap in knowledge by publishing articles with evidence showing that providing more of certain healthcare services doesn't improve health and can actually result in less health. Now, certainly the Archives is not the only one that's focusing on publishing articles on overuse. There are wonderful articles in JAMA by Rick Deo on the overuse of back surgery, how it's increasing complications and mortality. And then there are studies in New England Journal of Medicine about end-of-life care and how intensive care at the end of life with palliative care, with less intensive care and palliative care actually lengthens life. So the Archives, though, has this section deliberately focused on publishing evidence. Here's one of the examples of the research that was funded and published. It was a group of NCI researchers at the National Cancer Institute, and they estimated that 70 million CT scans that were performed in 2007, that they might actually cause 29,000 excess cancers in Americans and 14,500 deaths. And 2/3 of those deaths would be in women. This was a study that garnered a lot of attention in the media. And I will say that the media has been a very important focus by communicating these messages about overuse to the American public and stimulating the beginning of a dialogue and public awareness. This is a quote from Dr. Rita Redberg when President Obama had his physical exam in 2010. When you're president in the United States, nothing is really private. Here's what she wrote, and this was picked up by the Associated Press and got a lot of attention in the media. She wrote, "I was troubled to read that the president's physical examination included an electron beam CT scan for coronary calcium. This screening test likely exposed Mr. Obama to significant radiation unnecessarily, increasing the risk of future cancer. A single electron beam CT scan is estimated to result in a lifetime excess cancer risk of 9 additional cancers per 100,000 persons for men." So here we are, the President of the United States has a diagnostic imaging test, and we have leaders in the medical community who are reporting and questioning on it. Also in the Archives of Internal Medicine recently, we published what we call the top 5. These are top 5 things that primary care physicians came together in a consensus process and said, you know what, we could really be doing a lot less of these. And the process was undertaken by the Good Stewardship Group funded by the American Board of Internal Medicine Foundation. It was a voluntary effort, and here are some of the things that they came up with. This article is in your list of handouts online. So among the top 5 in primary care was don't do imaging for low back pain within the first 6 weeks, unless, of course, there are red flags. Don't obtain blood chemistry panels or urinalysis for screening in asymptomatic healthy adults. Or this one, don't order EKGs or any other cardiac screening for asymptomatic low-risk patients. And there are others. You know, for that one, I think of my colleague who shared an office next door to mine at the Robert Wood Johnson Foundation. She was 42 years old. She was a mother of 2 children. And I started asking people as I was doing this work on overuse, have you had medical care that you thought was unnecessary? And my friend and colleague Lori said, you know, when I'd go to my primary care physician for my annual physical, I would always get an EKG. And I always wondered why. There's no history of heart disease in our family, and I have no history. And my husband gets one too. Is that really necessary? So we're seeing a growing awareness among the public, questioning possible overtreatment. Here's another study that was published in the archives. It was a survey of U.S. primary care physicians. It was done by Brenda Sorovich from Dartmouth. And she found that 42% of U.S. primary care doctors think the patients that they see receive too much medical care. And what's especially interesting is that more than 25% believe that they themselves provide too much care to some of their patients. The good news is that about 3/4 of those who were surveyed said that they'd be interested in comparing their practices with those of their colleagues to note variation. So there's opportunity here and willingness for improvement. What about the public? Where is the American public on this topic of overtreatment? As was mentioned, I wrote a book called The Treatment Trap, and it focuses on translating evidence for the public into terms that they can understand. And what actually drove me to do that was the survey result that I found. It was a survey funded by the Commonwealth Fund of New York. And they observed that 32% of Americans reported that they've had medical care that they thought was unnecessary. I thought that was really interesting. And then you had the 42% of physicians who are saying that their patients are overtreated. So somehow there's some awareness going on. There's too much medical care being provided. So here are my two favorite questions. And in a minute, I'm going to ask all of you, with a show of your hands, how you might answer these questions. The first one is, have you or someone you know had medical care that you or they thought was unnecessary? My goodness, that's extraordinary. The second question is, have you or someone you know declined treatment recommendations and sought a less intensive, medically appropriate alternative? Show of hands. That's extraordinary. Of those who raised your hands, how many of you are from outside the United States? That's extraordinary. I don't feel so bad now. You know, when you're spending 18.6% of GDP, you're going to have a whole lot of overuse. But it's extraordinary that we're seeing this in other countries as well. When I asked this question for the first time at the National Patient Safety Foundation breakfast breakout, there were about 35 physicians and nurses in the room, and 80% of the hands went up in response to both of those questions. And you know why I like these questions? I think if we're going to tackle an issue like overtreatment, which is fraught with all the financial and professional issues, what we need to do is have people reflect on their own personal experience first, their own experience as patients and as family members. You'll find that many doctors have avoided unnecessary medical care, or in retrospect, they've had unnecessary medical care. And my colleagues say, well, physicians are getting this care, what about the rest of us who are not? What do we do? So I think this is a great way to start. And I urge you, when you go back home, before you even start any improvement efforts or even bring up the possibility, ask your colleagues these questions to generate dialogue about their experience and drill down on it. What was it? How did it happen? What would you do to prevent it in the future? And what's so extraordinary about the responses to these two questions is that perhaps for the first time in the history of medicine, we have a subset of patients who are informed, activated, who are declining doctors' treatment recommendations because they believe that they won't be better off. That's really remarkable. And people are doing it not cavalierly, but very carefully. It's a sign of something. And that is also, to me, a sign of opportunity. How do we tap into that? I have the pleasure and honor of participating for a number of years in the Dartmouth Summer Symposium. And during a coffee break on one of those days, I was talking with one of the participants there. She was dean of a Midwestern nursing school, and I told her what I was doing on overtreatment. And just out of the blue, this is what she said, and it was riveting. She said, health insurance used to be about giving patients access to providers. Now it's about giving providers access to patients. What a sea change. I don't know if that would be the experience in your home countries, but this was the experience of a mild-mannered, very sharp dean of a Midwest nursing school. One of the challenges that I think we all face, no matter our country, is how do we communicate to the public about the fact of overuse? We have a chapter in the treatment trap called The Marinated Mind. Our minds have been marinated to believe that more is better. Just have to turn on television. In the old days, 30 years ago, and I'm dating myself, there used to be a GP or family physician on television called Dr. Welby. Now we don't have primary care doctors and GPs on television. We have neurosurgeons in a program called The Gifted Man. And there was a segment on this program, it was really quite extraordinary. A young woman who's about to get married in a few days comes to see him. She was preparing for her wedding and she faints. And her mother was very concerned. And she brought her daughter to a doctor whom she knows, who is this neurosurgeon. And he tests her reflexes and nothing seemed to be out of the order. And he said, well, have you eaten anything? You know how brides want to slim down before their wedding day? She said, well, I have, not really. I've not been eating that well. He said, well, it's probably nothing, but let's do a scan. So we did a scan, and of course it showed nothing. And then at the end, he writes out a prescription, and for what, I can't recall. But this is what is being shown to millions of people, and they develop the expectation that this is good care, isn't it? So how do we rewind this? How do we put the genie back in the bottle? And you'll recall, some of you, in the United States when the U.S. Preventive Services Task Force report came out with recommendations on whether women in their 40s should have mammograms. And that caused a huge hue and cry. And more recently about PSA screening for men. As I've been thinking about this, what I've come to the conclusion, and you might have a different point of view, and I'd love for us to have a dialogue about this, is if we want to start talking about overtreatment and really make some progress, maybe we shouldn't be starting with those things that involve the C word, cancer, and screening, and where there's different points of view and also a lot of uncertainty. Maybe there's other places where we can start, and I'll give you some examples in just a few minutes. One of the emerging advantages that we have in the U.S. about communicating evidence to the public is we have a group called Consumers Union, which publishes a magazine called Consumer Reports. When I was growing up, we used to have this magazine and next to my dad's chair in his magazine rack. And if you ever were buying a car, you always want to consult Consumer Reports, or if you're buying a computer or a cell phone or getting a cell phone plan. It turns out they've hired a physician from Oregon Health Sciences University, Dr. John Santa, and he's head of their Health Ratings Center. And he's beginning to tackle this issue of overtreatment. So here's health ratings that Consumers Union put out for health screening tests, for heart screening tests. And this is for a gentleman who's in his, say, average age 55, asymptomatic, no risk of heart disease. And notice the rating legend. They have the red dot. And the red dot means benefit very likely, you should really go ahead and do it. And the black dot means no, you probably shouldn't. The benefits are none, the risks are moderate, and the cost is moderate. So here we have Consumer Reports coming out with ratings, and they suggest, sure, you want to get your blood pressure tested. You want to have your cholesterol tested. But you know that EKG, see that down below? Based on the recommendations from the primary care physicians, you probably don't want to do that. Consumer Reports also came across and developed a list of the top 10 surgeries that you should avoid. At the top of that list was back surgery. And also on that list was cardiac bypass surgery. This is a picture of a gentleman. It's not a great photo, and I apologize for that, but his name is Ron Spurgeon. He's a retired millwright from Northern California. He was one of 700 people who had heart procedures that were medically unnecessary. It turns out there was nothing wrong with his heart. This happened up in California about 10 years ago, and it was a very celebrated case. What was so interesting is that this data was out there in the Dartmouth Atlas showing this hospital where he had a surgery was the absolute highest in the whole country. But the public didn't have ready access to that. Can we change that to inform the public about these outliers? That's something that Consumer Reports is giving attention to. And of course, as mentioned, I wrote the book called The Treatment Trap to help communicate to the public about the fact that we have overuse. And I was honored to have the foreword written by Jim Guest, who's the president of Consumers Union. And we donate proceeds to a good cause. And I hope that you'll take it and use it to stimulate dialogue, even in your own families, as well as your places of work. How do we begin to crack this nut from an improvement perspective? Where do we begin in this thorny thicket of overuse, where issues of money and professional prestige are so pronounced? I have a few ideas here, and I'd love to know what you think. But I think it's so important how we turn evidence into improvement. What type of contextual factors will help us do that? And here are 4 things that I think that we need. We need evidence of harm. We need professional standards and consensus. Gee, you know, we really shouldn't be doing that. The other thing that I think would be really helpful is data that's specific to institutions, say a hospital or a practice. And even better, what if that information were publicly reported? Here are 2 examples. Early elective deliveries at 37 to 39 weeks. There's clear evidence and professional standards. The American College of Obstetrics and Gynecology says elective deliveries with no medical indication from 37 to 39 weeks is unacceptable medical practice. Clear cut, no equivocation. What do we do about that? And there are studies showing that there's earlier use of induction has resulted in more infants being delivered at earlier gestation. And concurrently, there's been a significant fall in mean birth weights, which places infants at greater risk for mortality and are linked to chronic diseases. And what's happening is that we're delivering infants without full brain development and without full lung function. So clear risk of harm that's understandable to the public. The other thing that we have here, thanks to the Leapfrog Group, which is a group of purchasers and employers, and they engaged 773 hospitals to voluntarily report the percent of births that are elective induction or C-section without a medical indication between the 37th and the 39th week of gestation. And here are some of the results. And they had data from 2010 and 2011, and you can see some comparisons. So here's Kaiser Foundation Hospital in Vallejo, California. 37% of the births were without medical indication, the early induction at 37 to 39 weeks in 2010. They obviously did an improvement at exercise and lowered that to about 5% for 2011. Then we have a hospital in New York, just north of New York City. They had a 31.4% rate. In 2011, it went up. Another hospital in New York, they were at 94%. And in 2011, they chose not to report. I think you get the picture. The good news is that this is publicly reported information now, and it was in the news media. And so journalists call up their local newspaper, call up their local hospital and say, could you comment on this, and what are you doing to improve? So we see this entering into the public dialogue. The good news is it's also stimulated improvement. Physicians in the 20 largest hospitals in Ohio were asked to document a medical reason every time a woman was scheduled to deliver before 39 weeks. In less than 15 months, the percent of early deliveries between the 37th and 39th weeks without a medical indication declined from 15% to under 5%. And the other thing that's happening is there's some reduction in the use of NICU beds. At the University of Chicago, the Women's Care Center implemented a hard stop whereby an induction or cesarean delivery prior to 39 weeks was prohibited without prior approval. And a bi-monthly peer review process was established to determine the impact of the protocol. And the early election deliveries from 37 to 39 weeks declined from 14% to 4%. So we have a combination of evidence of real harm, professional standards coming together, data that's publicly reported, helping to reduce unnecessary medical interventions that can cause more harm than good. Here's another example, the overuse of double chest CT scans. I don't know if this is something unique to the US context or whether other countries face this as well. I'll just move along here. The National Quality Forum is a place where they develop consensus around performance measures. And what they came to agreement on is a double chest CT scan is when patients have two imaging tests consecutively, one without contrast and the other with contrast, which yields a double radiation dose. And the National Quality Forum developed a professional consensus process, and they said that patients should have one, but they should not have the other. Why is that? We had professional norms coming together. What do we do about it? The good news is the Federal Hospital Compare website, this is the Medicare program, actually provided hospital-specific data on the use of double chest CT scans. And so all you had to do if you were really interested is you could type in your postal code or zip code, and the hospitals in your area would come up, and you could see if they had a red dot showing high use of double chest CT scans. Most hospitals didn't do too badly, but there were more than 600 hospitals where at least 10% of Medicare patients had a double chest CT scan. In 94 hospitals, nearly half the patients with chest CT scans had double scans, and they were clearly the outliers. So who comes along but the New York Times and also the Washington Post? And they developed this very nifty interactive map that you could use and pinpoint your hospital. And it was a great story for journalists in their local communities. If their hospital was an outlier, they would call up and do a local story. So here we have a combination of evidence of something we shouldn't do, professional consensus coming together, and data that's publicly reported, and fortunately the media being an important component in this change process. I want to address a point that sometimes comes up. I don't think it will come up in this audience. But is all of this rationing? And just to be clear, rationing is the withholding of beneficial healthcare services. Curbing overuse is withholding healthcare services that can actually cause more harm than good, and therefore is not rationing. A really important message. So in thinking about how do we begin to do the work of improvement in a way that will add value and not cause front page newspapers to be telling terrible stories like we had with the mammogram issue for women in their 40s. Is this a place to start where we have evidence of harm and professional standards and data to show? And it can make sense to the average person on the street. I hope as you do your work on improvement and encounter topics of overuse, that you consider the Archives of Internal Medicine as a place to publish your research. It's also a place where we've started patient narratives of their experience of overtreatment. We're encouraging submissions from patients as well as clinicians. And here we're having data. Data persuade, but emotion motivates. How can we put the two together and tell the full picture of overtreatment? This is a wonderful quote from the British Medical Journal from 1953. I ferreted it out from a oncologist colleague who works in palliative care. And back then they said, from the ability to not let well enough alone, good Lord, deliver us. And I think that can be our mantra going forward. You know, so far, I haven't mentioned dollars and cents and why addressing overuse is really important for us from a financial perspective. And the reason is that the first and foremost reason we should address overuse is because it is a quality and safety concern. But it also is a financial concern. This is a new book that I wrote that is just coming out this week. And it looks at the financial trajectory that the United States is on, with healthcare spending at 18.6% of GDP and growing and with no end in sight. That is not sustainable, and we are headed for a financial cliff. And healthcare is a very important, not the only, but a very important contributor to that. We have to find a way to reduce the overuse and provide the care that people need. Otherwise, down the road, we'll have a contraction far more severe than what you're seeing here in Europe. If we can learn how to address overtreatment now, this is sort of our training wheels, we'll be able to figure out how to take out the things that don't add value, so we'll have enough resources to make sure that we can take care of everybody. This is my contact information. If you'd like to have any questions about submitting to the Archives of Internal Medicine, I hope you'll feel free to call me or email me. And before I close, I'd like to leave on a note of sort of inspiration. Before I left for this trip, I live in the Washington, D.C. area in Arlington, Virginia. And I went down to Embassy Row, which is along Massachusetts Avenue. It's a beautiful part of stately homes where the embassies have their place of business. And outside the Indian embassy is a very modest but stunning statue of Mahatma Gandhi. And Gandhi is standing there with his stick and his wire-rimmed glasses. And there's a beautiful quote from Gandhi that is in the marble there in that memorial. And I think it's apropos of our conversation today on overuse. And let me repeat that quote for you. Gandhi said, "Whenever you're in doubt about what to do, find the face of the poorest man and ask yourself if the step you contemplate, will it do him any good? Will he be better off because of it? Then your doubt and yourself will melt away." Thank you for all you do to make healthcare better and safer for so many people around the world. It's noble work. Thank you for doing it. I'd be delighted if we could have some Q&A and conversation to keep this dialogue moving forward. Thank you. Yes. Can that microphone be turned on so we can hear you?
Is it on? Yes. Is that okay?
Yes, thank you.
I really enjoyed that. One thing I'd like to slightly, not exactly disagree with, but maybe change the balance. I mean, you said we need evidence of harm. And I remember when I was a young doctor hearing Sir Derek Dunlop speak, who set up the Committee on Safety of Medicines. And he said words to the effect that all effective treatments have adverse effects. If they don't have adverse effects, they're not effective. And I think that's absolutely right. And my area of interest is antibiotics, and people often say unnecessary antibiotics drive resistance. Right. But it's actually all antibiotics drive resistance. The unnecessary ones don't have any benefit. And maybe I don't think it's up to those of us who are skeptical about a treatment. It's not up to us to show the harm. It's up to the advocates to show some net benefit.
A word about the harm and the reason I focus on that. There's so much uncertainty about certain tests, procedures, surgeries. And if we're going to start with the work of improvement, just starting, not that we end up there, and we want to engage the public in understanding the fact, to change this marinated mind, at least at the outset, can we start with those things where there's clear, unequivocal evidence of harm? It's not that we shouldn't do things where there is no harm, or there will always be something. But if we're trying to take on this as a national agenda, that's the reason that I focus on where there are things where there's clear evidence of harm. So your point is very well taken. Thank you. Yes, over here, sir.
I'm really privileged to be here today.
We are privileged to have you.
Yes. Had I not made a decision to leave India like 20 years back, sometimes I don't know whether I regret or not, I always think about it. But I had the privilege of working in 3 different continents, so I have different perspective. One of the things when I left India, carried forward to different countries, Britain as well as United States, was turned down. What is that was, just like a gentleman was talking about medications. Digoxin is a medication, is one of the important medications for readmissions rate in the elderly people or over-hospitalization in the elderly people. In India, there is a very simple solution. They used to call holiday. Like they used to give a small dose for elderly people, only for 5 days in a week, and 2 days off. And we hardly see any elderly people with digoxin toxicity. I think there is a role for IHI to promote such interventions, and which are time-tested, and then we can show the evidence, because the pharmacokinetics will help that. It accumulates if you give it every day in elderly people with a compromised renal function. So what I would suggest is to promote such ideas across the board, which will definitely address the misuse and overuse of hospitalization.
Wonderful. I agree with that, and you can help us in that process of spreading these good practices. Thank you. Yes, sir.
Antti Malmivara, Helsinki. Thank you for the excellent presentation. I would like to ask, what is the impact of for-profit healthcare organization in comparison for not-for-profit healthcare organization? What is the research evidence on that issue, and what is your personal view? Thank you very much.
Thank you for your question. I'm not aware of the evidence. It may exist, but I don't know it, of the extent of overuse in for-profit versus non-profit facilities. That said, I do believe that in our market capitalist system, we have every incentive to do more, whether it's a pharmaceutical company, device manufacturers, hospitals. They're under the pressure to meet financial targets demanded by Wall Street. So that's a fact of life in which they have to live. And so that affects the system of healthcare. So my personal view is it certainly is a contributing factor, not the only factor. Thank you for your question. Yes, here. Yes, ma'am.
Oh, sorry. I was looking at your image, and I didn't see that you were looking at me.
Oh.
Thank you for a very interesting presentation. My name is Leah de Nouden from the Netherlands, and I have encountered some of the things that you're telling about. At the moment, we're looking into overuse of CT scans in children, and one of the problems we encountered is that, for instance, in guidelines on cystic fibrosis, there's a number of stated times that you should use a CT scan to follow up. And probably we need a review of the guidelines to do things like that. And the other one is a very recent paper in the Dutch journal. It was a team that was called How Doctors Die, and it's about end-of-life care. And there's really a problem how to prevent your patients from getting end-of-life care that as a doctor you would never want.
Right. Wonderful questions. I think that with campaigns that we have here in the U.S. that might be similar to yours, the Image Gently program for on behalf of children to reduce unnecessary CT scan use in children. I think we have the opportunity now to look at what is the radiation exposure and to actually track it over time. If you look at surveys of physicians, many physicians are just simply not aware of the fact of the radiation dose, nor the cumulative radiation dose. And certainly in children, the issue is far more pronounced than it is for adults. So I think we have an opportunity to revisit guidelines in light of information on the risks and to balance those benefits and risks together. Your point about end-of-life care, perhaps you're referring to the same article, but in the Wall Street Journal a few months ago, one of the most top looked at articles was how doctors in America die differently from the rest of Americans. So what is it that they know that we don't know? It's a really important question. But even more important is how do we, as ordinary Americans who are not physicians, able to access care that is consistent with our preferences and values rather than what the system may want to offer us. And I know Maureen at IHI is working on a conversations campaign to help inform the public about their choices and their options at the end of life and how they can have their preferences and values for care honored. We have to take that and keep it going, and deepen it around the country. But thank you for your comment and question. Yes, sir.
That was very nice. One quick question, and I think you touched upon it a little bit. Michael Porter also talks about the waste that arises in healthcare from competition, a litigious environment, and the failure to control costs, by negotiating prices of, say, innovations and medications. We seem to shift the gatekeeper function on healthcare. Who is the real gatekeeper of this? From the physician to the patients to the insurance companies. Do you think that the current healthcare reform in any way addresses the real gatekeeper of cost as we go forward and quality, or does it shift the burden from one to the other?
That's a really interesting question, and it's a topic I address in the Battle Over Healthcare, which looks at the healthcare reform law. The thing that surprised me, and I went with sort of an open mind in examining this health reform law, there's nothing in the law that stops the increase in the cost of private health insurance. Secretary Sebelius was interviewed on one of our nightly news stations, and in that interview, she was asked, what should people do when their health insurance premiums keep going up? And her response was they should go to their state legislature and governor and advocate for legislation to do rate review for insurance. That's an enormous task. So we don't have a way in our healthcare system to try to control private health insurance premiums. There are provisions to try to put a limit on the growth of Medicare spending, but that's under a lot of contention in Congress from those who really don't want to have any limits on spending. We have time for, say, one more? No? Oh, no, I can't go anymore, but I'll be here and would love to continue the dialogue outside in the refreshment area. Thank you very much for all you do for your patients to provide them safe and high-quality care.
And thank you very much, Rosemary and Maureen, for two fantastic presentations. And we now know that these was two authors that have launched their books this week, so it's just on time. Please be seated. We will start again in 15 minutes in this room with the keynote. Thank you very much for attending.